The best teachers are those who show where to look but don't tell you what to see. With that quote, I would like to call upon our next speaker, Professor Dr. Mangal Bharti. Sir has completed his DM in neonatology from PGI Chandigarh. He is currently the head of Department of Neonatology, Institute of Obstetrics and Gynecology. The NICU managed by him by his department under his guidance is the largest in the country. Today, he is with us to discuss approach to preterm.
So, very good afternoon, everyone. I have been asked to speak on, I think our time slot has been divided into two. I will be speaking on preterm management, and Kamal sir will be touching upon jaundice. So, well, the time available is very small, but we understand well, small is our specialty. So, smaller the baby, smallest the baby, the challenges are more, and we thrive on small. So, all of you know these well. The first question, so today's focus will be more on, we do understand the word preterm just implies a small newborn and an immature newborn. So, when we talk about management of a newborn, I think that's what we try to teach over a period of 3 years to our DM postgraduates. So, primarily 37 is the cutoff, we all know. Less than 37 is the standard definition of a preterm, but various new definitions have been devised over a period of time. So, students need to be aware of why these new definitions have come up, and so what are the meaning of those definitions. I think all of you know this period from 34 weeks to 37 weeks is called as late preterms, okay, fine. But now we think we understand even at 37 weeks the babies are not fully mature. I think there is enough evidence to prove that babies achieve their full maturity only when they cross 38 and go to 39. So, a new term has come up. What is this called? Okay, from 37 to 39, 37 to 38, 6 by 7, we call these babies as early term babies. So, just please be aware of this terminology. What is an early term? The term full term means a baby who has completed 39 weeks. And there are many terminologies below 34, very preterm, extreme preterm, micropremi and all. So, for this session, I think just from the exam perspective, this is an exam oriented discussion, and it's very unlikely, and I don't think you will be given a baby who has gotten any acute problem, and usually you don't get babies who are less than 34 weeks of gestation. You will be getting a baby, and even if it's going to be somewhere around 32 to 34, you will be given babies who are stable, who are on feeds, who are without any major pathology. So, no point in discussing the acute respiratory or other management of these smaller babies. So, I will just try to focus or touch upon the very basics. Maybe at the end of the session, many students here might think that there is nothing new to learn from this. That is fine. So, exam is all about getting through and getting a pass. So, problems happen in both the directions. Like students having difficulty in understanding even very basic questions. That's one of the common reasons why they have difficulty in clearing exams. The other side is that even though the questions are basic, so people make mistakes with confidence. They think, oh, sure, I know the answer well. So, only basics which you are likely to come across the questions, and it's going to be just a rapid fire we will run through. So, this we have already discussed, but just because you have got a small baby, don't jump to a conclusion that this baby is going to be a preterm baby because of the situation prevailing in India. So, we know that we do have a very high number of these growth restricted small for gestational age babies. So, even though just around 30% of our deliveries, more than 1/3 of our babies are having a low birth weight, but there is a major chunk coming from small for date. So, just you have to be very clear in these terminologies. Even if it is a preterm baby, that baby might have had some growth restriction. So, understanding these terms is very important. Obviously, so this is a very, very important domain because most of the neonatal mortality as of now is only from these low birth weight babies. Bigger babies hardly get into trouble. So, the first question will be like, okay, what are the common reasons for prematurity in India? I think Maternal nutritional status is very important. So always your history should talk something about the weight of the mother, especially the weight gain that had happened during pregnancy. And now it's an era of ultrasound. So please don't forget to ask about the growth status by ultrasounds, and especially the status of Leica, which are very good indicators of the intrauterine growth. So maternal growth status, the age of the mother, multiple pregnancy. This history is a very, very important history. Even if you don't know anything, just if the mother happened to have a previous preterm pregnancy without having any of the morbidities, PH, diabetes, whatever it is. So that has been shown to be a single most important risk factor for having a preterm baby again. So always in the history, never miss a history of a previous preterm baby. Of course, cervical incompetence is a major factor, and factors like bleeding, any systemic illness in the mother, and the so-called iatrogenic preterm. More and more we are having babies who are being induced prematurely because of various reasons. So that is what is called an iatrogenic prematurity, and it's okay for you to say that the cause is unknown. Even after going through all these things, there is a big chunk of preterm babies where you won't be able to attribute any cause to prematurity. You can say, okay, I went through these common factors, I'm not able to find any factor. This looks like an idiopathic prematurity. That's fine. So have I missed any one important factor? I intentionally missed it, thought somebody else will pick up, which is not shown here. Premature rupture of membranes, PROM. So premature rupture of membranes again is a very, very important cause of prematurity. On the contrary, when you're talking about growth restriction, so I didn't bring in PAH and other diseases earlier because primarily hypernutrition, toxemia, anemia, these lead more to growth restriction rather than causing prematurity, and of course multiple pregnancy, post-maturity illnesses in the mother. Okay. So once you just get a preterm baby, first thing you are looking for, what is the cause of this preterm? Can I just, these common causes, you need to find a cause by history taking, and then just the second thing comes that, okay, so what can we do about it? As at least, what are the input that's going to come from pediatrician to the obstetrician? So we are interested just in 3 major interventions as of now, which can be done in the antenatal period, which has got a very big impact on the outcome of these babies. So what are these? Though never forget these 3. So all your history, if you get a small baby, should talk about these 3. Whether the mother had received antenatal corticosteroids. Okay, so we all know the standard recommendation of the government, 24 weeks to 34 weeks of gestation, and the recommended steroid as of now is by the government is dexamethasone, not betamethasone. So there is a government program, government recommends dexamethasone. Okay, so 4 doses of dexamethasone. So and you all know that what do you mean by a complete course? A complete course offers a better benefit, but even a single dose of steroid offers a significant benefit. So we should try to give as much as possible. The best effect for steroid, when somebody asks you when it is achieved, you need to wait for a week after a complete course of steroids. Give a complete course of Dexa. After 1 week of a complete course, you expect the best results to happen. What is the second one? Intrapartum antibiotics to the mother. This is not an intervention for every preterm onset of pregnancy. If there are risk factors in the mother for an infection, especially if there is premature rupture of membranes, or if the mother has got features to suspect the possible chorioamnities, like she has got fever, high WBC counts, the so-called foul-smelling liquor, so all these. So one intervention that's very, very crucial is administration of antibiotics to the mother in the peripartum period. So as for intrapartum antibiotics. And the third one, this is only for babies who are less than 32 weeks of gestation, or say less than 1.5 kg of birth weight. This was an intervention you would have seen commonly used for managing eclampsia and impending eclampsia. But now, so this has been shown to have significant benefits from the perspective of neuroprotection. So we are recommending, and you would have seen in IOG, most of our babies who are getting delivered in less than 32 would have received a course of intravenous magnesium sulfate for the mother. Okay. So again, note down these 3 and just bring them in your history. So differentiating or identifying whenever you say preterm, obviously the examiner will be interested in, okay, can you just assess the maturity, how preterm is this, and is there a small for gestation age component, or can this be SGA rather than a preterm? These are very common questions. All of you know this, but even though there are many things to do, still a lot of importance is being given to the last menstrual date of LMP. By science, we know that if somebody asks you what is the single most or the best parameter to estimate the gestational age of a baby if records are available. It has moved from first to two now. The so-called dating ultrasound or the first trimester ultrasound is the number one factor or the best factor to estimate the gestational age, because there could be some probabilities the cycles don't remain the same for every human. The calculations have some range of error when you talk about LMP, but again it comes very close to ultrasound. So at least just ask about not only the LMP, ask about whether a first trimester ultrasound is available. Don't try to estimate the gestation based upon a second trimester or last trimester ultrasound. The range of error is quite high in those, even up to going up to 10 days, up to 2 weeks. So the later the scan, there will be a high chance of you making error about the gestation. Okay, so I think we all know about the various physical factors that we use to differentiate between a term, preterm. And what is this chart? Okay, so this is a new Ballard score. Okay, so use the term Ballard's was an earlier device. This was upgraded much earlier. So the new is not new anymore. This score is called as a new. It's there for so many years. This is a modified Dubowitz or a new Ballard's score. So at least just remember, nobody will expect an MD candidate to do a new Ballard score in full, but with just maybe examiner may be interested in just assessing whether you have done it during your clinical postings. So just remember there are two major components. One is a component which assesses the neuromuscular maturity. And neuromuscular maturity, there are 6 components. It's very easy to remember. Okay, so I'll say that it's just related to the joints. Just remember the joints. The first one is about the overall posture of the baby, how the baby looks. Okay, the second one, just remember the 3 joints of the upper limb. Okay, what is there in the wrist joint? Square window. What is there in the elbow? Arm recoil. You flex and just release. You just see how much recoiling happens in the elbow. What is there in the shoulders? Scarf. Okay, easy, no? So 3 joints. Just posture, okay, square window, arm recoil, and then the scarf. There are only 2 things again, the legs, the knee joint and the hip joint. What is there at the level of knees? Popliteal angle. What is there at the level of hips? Heel to ear. I don't think anyone will forget. You just have 6 things that assess the neuromuscular maturity of a preterm baby. Use these 6. Forget about what scores are being given there. You don't need to remember those numbers. That's not necessary. And obviously, again, there are another 6 parameters. I think you'll know these things. We'll skip these. So what was new? Or somebody asked you, why do you call it as a new Ballard score? What was the modifications made? And if somebody asks you, can you just, based on the score, can you tell the gestation? It's very easy again to remember. So just remember earlier, what was the viability was at 24, no? The viability starts at 24, even now. The standard recommendations is 24 up to 40. So just, this was the earlier one. So that means the score of 0 corresponds to a gestation of 24, and then we have a score of 40 corresponding to 40. Very simple. So later people thought, okay, so it became necessary to estimate even babies who are less than 24 weeks of gestation. There was no way of adding anything to that. That's why the negative scoring was brought in. The original Ballard did not have any negative scoring. All this was only 0, 1, 2, 3, 4 only. So the only way of modifying was without bringing in a confusion. That's why negative parameters were brought in. So you go down like 22, 20, okay. From 20 weeks up to 44 weeks, you will now be able, at least remember these 2 numbers, 40 corresponding to 40, 0 corresponds to 24, or some components. So the negative components are all primarily in the physical scoring systems, not primarily in the neuromuscular maturity. Okay, I think you'll all be able to describe this. Don't make any mistakes. I think all this is available from NNF teaching module, which is available free online. No worries, you can all go and Google, get it. So we know how to differentiate a preterm breast from a term one. Look at first the size of the whole size of the areola. Rather than the areola, what are we interested in? We measure the nipple bud, size of the nipple bud in terms of millimeters. So 2 things we look into: what are the size of the nipples in millimeters width, and then the size of the areola. Look into the pigmentation. Just see the term will have a good pigmentation, whereas the pigmentation is absent here. Okay, then the whole thing will have an elevation. It is an elevated areola. You'll feel the tissue underlying in a term baby, whereas this will be a very flat one. Okay, so describe. So these are the common things that you are expected to, when you say at least use this word. This is a flat breast without a breast tissue, not pigmented. Areola is the width is very less, and it has got a very small nipple bed. So this suggests it's a preterm baby. Fine, that will be okay. I think genitalia, again pigmentation, rugosities, whether testes have descended or not. We're talking about preterm genitalia. Again, what to say, labia majora and minora and the clitoris, prominent clitoris, very visible majora not covering the minora indicates prematurity. Sole creases, some people sometimes get confused. See, we are not giving importance to all the creases. So, what we are interested in? We are interested only in the deep sole creases. We don't take into account the superficial creases. So, just don't get misled by some creases which might be superficial. And we know it moves from anterior to posterior as the maturity becomes more and more. So, if from starting from here and then it goes downwards, look only for the deep creases. Okay. Of course, the whether helical pattern, and this is you can do by palpation, folding, whether recoiling of the ear cartilage. The maturity of the cartilage is assessed in the ear. Okay. So, how do we, okay, these we know are the primary physical characteristics we use to recognize a preterm baby. What about a small for gestational age? And so, many of our preterms, as I said already upfront, they may have a component of intrauterine growth restriction. Okay. So, you have to bring out those. So, these are not features of prematurity. Anybody who is having an emaciated look, loose folds of skin, lack of subcutaneous tissue, and a difference between head and chest. Head looks larger than the chest, at least by more than 3 centimeters. Very basic things to suspect underlying intrauterine growth restriction. Do we have any objective ways of assessing presence or absence, just like a Ballard, new Ballard? Do we have any? Yes, fantastic. So, what is this? So, at least just remember the name, what it says. So, those who are, what is CAN stands for? CAN stands for Clinical Assessment of Nutrition Score. So, nothing big, just about the same parameters what we are talking about, loss of subcutaneous tissue and more, folds of skin. If you just bring in, you just assess it to head to foot. There are some 10 parameters there. Just remember that there are 10 parameters. Again, you don't need to remember everything. But just there is a trick if somebody actually asks you, that's why I am saying, unlike the other scoring system, it is a reverse scoring. That means baby with the maximum, the baby with have a maximum malnutrition. The poorest nutrition gets a score of 1. Baby with the best nutrition gets a score of 4. So that means there are 10 parameters, a score of 40 means it's the best score. There is no malnutrition. If you are going to get a score of 10, there are only 10 parameters, that means each parameter is going to get a score of only 1. What does that mean? That is the worst score you can get. That is a baby with the very florid malnutrition. So, just to have an idea what it is, just see these are the ways the scores are assessed. These are various areas, just you look in from head to foot. You are just looking for how the subcutaneous tissue is, that there are markings given for you to understand the amount of loss of subcutaneous tissue and the wrinkling present. Look in the head and check. You are going to look around the elbows primarily, arms. You are going to look on the back how it is, and we are going to, especially the subscapular regions, we are going to look over the buttocks. The diagrams is here for you to have an idea. Also, we look in the legs, fine, and the chest and the abdomen. So, everywhere, head to foot, there are 10 regions, both anterior and posterior. You are going to assess the amount of loss of subcutaneous fat, and you are going, if you bring in a scoring system, what is the scoring system called? CAN score, Clinical Assessment of Nutrition Score. A simple score, that's fine. Again, all of you understand the importance of using a growth chart. If you have to, if somebody asks you what is the gold standard for finding out whether this baby is really appropriate for its gestation, the answer should be, I will plot it on a growth chart and I will estimate the centiles. Okay. So, obviously, so we all know that what is the cutoff stands at 10th centile. Whenever a baby is less than the 10th centile for that gestation, we are going to call it as a small for gestational age baby. But we know there could be a group called as a constitutionally small babies, where they may not have a growth restriction just because their family or parents happen to be small, the baby may be small. That's what is a constitutionally small. So, all SGA are not IUGRs. Baby who has got a weight less than the 10th centile plus something in history or an examination which suggests the presence of few factors which may be associated with malnutrition, whether it is intrauterine or postnatal, then we will call it as it's a growth restricted baby. Okay. So, again problems are many. You try to categorize and remember at least what are the births. So, starting from birth, we know that these fellows they can have problems just at the point of delivery itself. It is a preterm, obviously they are more likely to develop birth asphyxia. Okay. So, after birth, soon after birth, what are the problems? The primary problem is in adaptation, the respiratory system. They may not be mature, so you will be having the very high chance of respiratory distress syndrome. RDS is the primary problem. The same way, what is it related to breathing? The apparatus may not be good. The stimulus that is coming from the brain, what is it called? Apnea of prematurity. Okay. So what can go wrong with heart? Many of them will have a poor myocardial function. So these babies are more prone to develop perfusion abnormalities. That means shock. What else can happen in heart? They can have a PDA open. PDA can lead to problems. Okay. Coming down, so other organ systems, abdomen. Okay. Feed intolerances, necrotizing enterocolitis, liver, jaundice. Okay. So then, what are the hematological system? They can have over a period, their blood production will be much low. They can have develop anemia over a period of time significantly. Okay, so name any organ, you will be able to. Metabolic is metabolic. What is it? All problems. Okay, hypoglycemia, hypocalcemia, the hyponatremia in very small babies. These are the three major metabolic problems that they develop. Retinopathy. Okay, and single again put together in the skin. What is the major problem? Temperature maintenance. Hypothermia. You should talk about. Okay, so later problems, and they are very prone to develop infections. Asepsis becomes a main factor. So when somebody asks you what could be the problems, just try to remember just short term, long term based upon the organs. Okay, so these are specific problems of IUGR babies, not just preterm. If somebody is SGR, IUGR, what are they prone to? They were at a very high risk of developing birth asphyxia rather than AGA babies, more prone to pass meconium, having meconium aspiration syndrome and related complications. The incidence of hypothermia, hypoglycemia and infections is still increased further in these babies, and of course polycythemia. Okay, so we'll just run through certain points. I think I've got 4 minutes. We should run much faster. So if we are having a baby more than any baby, irrespective of the gestation, as much as possible. So for better temperature control in these babies' delivery room, please practice delivering the child on the mother's abdomen, so that early skin to skin contact is initiated. Okay, so then try to attempt practicing delayed cord clamping. Delayed cord clamping has got very high amount of benefits compared to the benefits in term babies. So it's multifold. Lots and lots of benefits in preterm rather than benefits for the term. It's a very crucial intervention for preterm babies. If you are not, again, just one word. If you are not able to practice delayed cord clamping, you are allowed, it is recommended now to do umbilical cord milking. Go for that. So just a warmer will not be enough for the baby in the delivery room. Think about using a polythene wraps. Polythene wraps are interventions that are required for again babies who are less than 32 weeks and less than 1.5 in the delivery room to maintain temperature. Don't intubate as much as possible. We don't want to intubate these babies in the delivery room. We just want to use non-invasive positive pressure ventilation. So always go for non-invasive, avoid intubation. What is the importance of ventilation? Using PWP. That means a simple amber bag, what you are using is not going to provide positive end expiratory pressure. So you need a TP's resuscitator to provide. This is a mandatory device when you talk about resuscitating preterm babies. There are a lot of recommendations. Oxygen can be very dangerous for these babies even in the delivery room. So there are targets given not only for preterm, that's good for even for term babies. So we need to have a blender and a pulse oximeter in the delivery room whenever you are thinking about resuscitating a preterm baby. Okay, so it's not necessary to hospitalize all preterm unless they are sick. So anybody who is sick, you will hospitalize. Otherwise, the standard indications are less than 34 weeks of gestation and less than 1,800 grams. This is a standard accepted criteria to decide which baby can go with the mother and which baby has to be moved to the unit. Indications for hospitalization. Okay, temperature maintenance, definitely some discussion will be there on hypothermia, brown fat, white fat, where it is, what are the various mechanisms, the various mechanisms of heat loss, how these devices help in minimizing the various ways of heat loss. So be prepared about a lengthy discussion on temperature maintenance in preterm babies. But just I want to emphasize about, we have already discussed about the polythene wraps. What is this one? What is it? Just at least if you remember the name, that should be more than enough. Pardon? Okay, this uses a phase changing material. This is a mattress, thermal mattress kind of device. So which is being used largely now, doesn't require any power source. Very handy. Okay, it's a commercial name is Embrace. Okay, I think I have a minute. I'll try to finish. Not to forget KMC. KMC, the common problems will be in all of you know the three components of KMC. What are the three components? Skin to skin contact, early initiation of breastfeeding, and early discharge. Please remember the three components. This doesn't stop with skin to skin care. Skin to skin care, early initiation of breastfeeds, and early discharge. So how do you do about it? Okay, I think all of you should be familiar. And just have three categories when somebody asks you how will you manage nutrition. So just babies who are less than 30 and less than 1.2 are the ones where you need to start them on initially on IV fluids and then start giving tube feeds slowly. Bigger babies, that means 30 to 34 weeks, 1.2 to 1.8, very well you can start them on gavage feeds and then move to spoon pallada feeds from the next day onwards. More than 34, more than 1.8, direct breastfeeds you can try with supplements. I think all of you know that. I'll just go to only a table. This table you all know. Compared to a term, that means the fluid requirements of a preterm are more. So whenever you are calculating the feed requirement, milk requirement, just remember this chart. Okay, feed just one or two other words. Trophic feeding. Just at least say, even if you are not able to start a good amount of milk, don't keep the baby nil per oral. Okay, so there is a big role for what we call as a minimal enteral nutrition. Read about the trophic feeding and the advantages of trophic feeding. Okay. And the only concern is in babies who are having some Doppler abnormalities, so-called absent or reversed end diastolic flow, or babies who have been put on indomethacin. Otherwise, you can very well be, as much as possible, try to get rid of the IV, progress with your feeds. In general, smaller babies less than 1250 can be fed at 2 hourly intervals. More than 1250 gram babies can be fed at 3 hourly intervals. So even in those with Doppler abnormalities, we assess the abdomen and then we proceed. Okay, feed intolerance, okay, I think I'll skip for want of time. So this question will obviously be there. How do you ensure or assess the adequacy of nutrition? How much amount of weight loss can happen over a day? What is the weight gain expected over every day? How do we assess? So we all know that cumulative weight loss in a term can go up to 10, little bit more, up to 15%, but not in all babies. The maximum loss accepted is 15% in preterms. These babies take a little bit longer time, up to 2 weeks to regain their birth weight. Then they get about 1 to 1.5% of their birth weight. The daily weight gain should be 1 to 1.5% of their birth weight. That much amount of weight gain has to happen once they regain their birth weight in a preterm baby. Okay, excessive loss or inadequate weight, the common reasons look for anemia, cold stress, nutritional intake, and think about the possibility of infection. Supplements, at least remember vitamin K at birth or all babies, vitamin D, 400 for a term. Preterm, a lot of confusions. If somebody is in exam is interested in the higher number, say at least 1,000, 800 to 1,000 international units for a preterm. Don't forget about iron. Even if you don't forget about calcium, phosphorus, doesn't matter for everyone. Just think about vitamin K at birth, vitamin D 800 to 1,000 international units, and iron as early as starting from 2 weeks. Don't forget this. Warning signs. This will be doing for a term baby, but it's very, very important. Discharge advice. This you have to remember. Okay, transportation, take care. And whenever some people ask you, so what is the prognosis? That will be the last question. Will this baby do well or not? It simply depends on what is the actual gestation at the time of birth, what are the morbidities that this baby had gone through, especially list of morbidities. And of course, if neuroimaging may play a smaller component. In general, if there is no major morbidity and the neuroimaging remains normal, the baby should have a largely better outcome. Okay, as I said, just my emphasis and the intention was to stay only with the basics. I think if you answer these steps clearly without any hesitation, and you can be 99% sure that your short newborn case, you will get through if it is a preterm baby. Thank you so much for the opportunity.